Hello, I am Dr. Sayantan Kundu. I actually based from Shiliguri, and I am attached with Neutia Gateway Healthcare Center and practice in Darjeeling and Shiliguri. So today we will present a case of 49-year-old male patient. So the patient having the 49-year-old male patient who is known diabetic since 2 years and having a history of hypertension with dyslipidemia, and his current BP is 138 by 82, BMI 28.5 kg per meter square, and the medication history. The patient was metformin 500 mg milligram initiated 3 months after the lifestyle management, and dose increased to 1000 milligram twice daily 6 months back when HbA1c was 8.3. And currently the patient on metformin 1000 milligram twice daily, amlodipine telmisartan FDC 5 by 40 on once daily, and rosuvastatin 20 milligram once daily. Currently her laboratory result was HbA1c 8.6%, fasting blood sugar 165 milligram per deciliter, ppg 280 milligram per deciliter, LDLC 120 mg per dl, and EGFR was 73 ml per minute per 1.73 meter square, and his HOMA B score is 100.8 and HOMA IR is 4.1, and patient having a history of hypoglycemia after seeing his close friend was hospitalized. So the primary clinical concern in this patient having the 49-year-old male and uncontrolled glycemia because his HbA1c 8.6% on metformin, obesity, there is a BMI 28.5 kg per meter square, and the additional risk factor is hypertension and is high urinaceer. Patient is a non-smoker and patient having a history of dyslipidemia. So when to initiate the combination therapy or the FDC? According to ADA 2021, the initial combination therapy in patient that presenting with the HbA1c level 1.5 to 2% above the target, according to ACE and ACE 2020, the early HbA1c greater than 7.5% to 9% considered dual or the triple therapy, and according to RSSDI and ESI 2020, that considered the initiating the combination therapy if the HbA1c greater than 1.5 above the target. So the possible effect of the combination in the cardiometabolic risk factor. Number one, weight and BP reduction. Number two, there is a powerful and early efficacy, CV and renal benefit, and the safety and the evidence of the individual component, and the low risk of hypoglycemia. And in this patient, the compelling effect is that the complementary effect in cases the HbA1c greater than 8%, there is a dual DPP4 plus SGLT2 that add on the therapy to metformin should be considered to help the more patient and achieving the glycemic targets. So further, there is a optimization of the empagliflozin and the linagliptin FDC that robust the reduction in the weight, blood pressure, and the serum uric acid at 52 weeks. And despite there is a high efficacy, there is no risk of hypoglycemia with empagliflozin, lina, fixed dose combination, and lower risk of genital tract infection in these cases. So the empagliflozin, linagliptin FDC that afford the early and to reboost up to 1.8% HbA1c reduction from the mean baseline greater than 8.5%, significant weight and the systolic blood pressure reduction, minimal risk of hypoglycemia, and lower risk of genital tract infection. So, but this is the enough. In cases, there is a combining the effect, there is both the empagliflozin and the linagliptin are recommended for the type 2 diabetes management, type 2 diabetes patient with CV disease or at the risk of heart failure, respectively, that reduces the CV event and the mortality in the class 1, the SGLT2 recommended the CV event, and the empagliflozin that recommended to the risk of the death, and the in type 2 diabetes perspective, the SGLT2 recommended to the lower risk of the heart failure risk, and the DPP4, sitagliptin, and the linagliptin may be considered according to class 2B. So in the renal evidence, the empiric outcome that show the 39% relative risk reduction in the worsening nephropathy or the type 2 diabetes, there is with ECVD. And according to Carmelina trial, there is 14% of the relative risk reduction in the progression to albuminuria in the type 2 diabetes. And according to the hepatic evidence, in patients with the type 2 diabetes with NFLD and the empagliflozin significantly reduces the liver fat and improve the ALT level, according to ELIF study. So, at that cases, and the empagliflozin and the both the EMPA and the LINA combination in the metabolic perspective, more than 1.8% on the higher baseline and the significant pleiotropic benefit in the weight loss and the BP reduction. And in CV perspective, there is significant 3P reduction, CV death, all-cause mortality, and heart failure benefit with EMPA and the safety with the LINA. And the renal perspective, the 39% according to empiric outcome, there is a 39% relative risk of incident with the worsening nephropathy in type 2 diabetes mellitus with ECVD with EMPA. And there is a 14% relative risk reduction that progression into the albuminuria in type 2 diabetes mellitus. Thank you.